Good morning, good afternoon, and good evening, everyone. Welcome. It is such a pleasure to have you here today, and a real pleasure for me to be here as well. My name is Rachel Cladd, and I am the Director of Partnerships and Alliances at the Broadreach Group. We have an exciting and informative panel discussion for you today on one of the most important issues of our time, of all time, really, and that is health equity. But before we get started, I'm going to go over just a little bit of housekeeping. We have people joining us from all over the world. Some of you are joining us today on Zoom. Some are joining via a YouTube live stream. Your questions are very welcome and encouraged. You can submit them at any time during the discussion. If you're joining us on Zoom, you can just go down to the bottom of your screen and find that Q&A button. You can click on that and you can input your questions there. If you're joining us on YouTube, you can type your questions in the comment section. We will answer as many questions as we can during the Q&A portion of our event. And where we can, our panelists are also welcome to provide some written responses to some of your questions. So that's it for housekeeping. Now, I have the distinct pleasure to introduce you to Dr. John Sargent, co-founder of the Broadreach Group and Vantage Health Technologies. A medical doctor by training, John has spent his career driving innovation in program management and in health technology to advance health equity around the world. John is going to start off by sharing the results of a recent industry survey on health equity, and he'll also be moderating today's discussion with our esteemed panelists as we explore ways to understand and take action on health equity in the payer-provider space. So John, over to you.
Great. Thank you so much, Rachel. And I just wanted to thank everybody who's joining us today on Zoom and on YouTube. I know your time is precious, and we really hope this next hour is going to be one of inspiration, one of learning, and one where you can hopefully find new folks to collaborate with as we all work on this important journey towards health equity. So what I'd like to do, as Rachel mentioned, this is going to be a two-part event. So I'll first go a little bit into the initial industry survey results we did, and then spend the bulk of the time talking to our panel. We've got an awesome panel lined up, folks from all aspects of the healthcare industry who are living and breathing health equity every day. So I think they have a lot of experiences, probably a lot of scars that they can share with you as they've started this journey. So before we start, I just wanted to introduce who we are and why we did this survey in the first place. I'm one of the co-founders, along with Ernest Darko, my best friend from medical school, of the Broadreach Group. The Broadreach Group is a social impact organization. We were founded in 2003, almost 20 years ago, with the purpose of improving access to healthcare and quality of healthcare for underserved populations. And we focused most of our work in emerging markets, and in particular, sub-Saharan Africa. So we've worked in over 25 countries working on health equity issues in really, really tough settings. So settings where the government provider side, the NGO or the private provider side is typically under-resourced, typically working in places that are only accessible by dirt roads or very little access to electricity or even sterile water for surgeries and medical procedures. And on the flip side, on the patient side, really severe SDOH issues. Lots of issues with food security, housing security, literacy issues, and even very different belief systems of healthcare. And so it's sort of through these 20 years of working in these 25 countries, we've developed a lot of learnings, we've developed a lot of techniques and approaches, and including our own population health management platform, Vantage, which is really focused on helping the health system optimize their performance in these types of settings through next best actions and intervention workflows. So we, about 2 years ago, decided that we wanted to come back into the US market. We felt that we had learned a lot and had sort of a breadth of experiences and some capabilities that we thought we could bring back to the health equity discussion here in the United States. And as part of our approach, and what's really important for us, our ethos is partnership and collaboration. We really feel strongly that to tackle these big challenges, you have to do it in collaboration with like-minded organizations and those that bring different skill sets. So it was in the spirit of collaboration that we launched our first industry survey on health equity in the United States, and really to give the results back to the industry, hopefully use this to continue the conversation, be a catalyst for new partnerships, new collaborations, new ideas, so that we can help keep together pushing and advancing forward this health equity agenda. Okay, so before we go in the survey, I just want to do a level setting, and if we could go to the next slide, please. So I just want to touch very quickly, how are we defining health equity? And so for the purposes of this survey and this discussion, we're using the CMS definition, which is that the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, and socioeconomic status, geography, preferred language, and other factors that affect access to care and health outcomes. So that's sort of the definition that will ground the discussion today. And then I think the second thing before we dive into the survey is, why should we even care about health equity? I'll answer that in two ways. I think first, when people choose to pursue careers in healthcare, whether it's as a clinician, as a administrator, in some sort of capacity or role, I think you quickly realize that healthcare is not a job, it's a calling. And we're all trained to do right by our patients and to do the right things. And so for me, very simply, being a clinician or being somebody who works with health systems, it's all about doing the right thing for the patient so that ultimately they can have the best possible health outcomes. But also from an economic perspective, there's a lot of compelling information and data coming out now. For example, the United States, it's estimated that we waste roughly $320 billion a year due to inequities in healthcare. And that's thought and estimated to go up to close to $1 trillion per year by 2040. Additionally, it has a big impact on our economy. It's thought that poor outcomes due to health equity or disparities are leading to roughly $42 billion in lost productivity in the economy. Okay, having sort of set the stage, let's actually go into the survey. And I'll do this very quickly. I think it'll give you a taste and a flavor for what we did. There will be a formal report, white paper, that will be issued on Tuesday of next week. And everybody attending this event will have this sent to you. If we can go to the next slide. So let's start off by who took the survey. So this was a marketing survey that we did, and we sent out through lots of different networks like the SNP Alliance and others to try to get a sense and a broad coverage of folks. So we had roughly 200 people responding to this. Approximately 60% came from payer organizations, roughly 23% came from organizations that are consulting or provide tech or data services, and 17% came from the provider community. Roughly 70% of the respondents were at director, VP, or C level. And for those who are managing large populations and plans, roughly 75% manage populations well over 100,000 people, and roughly 29% were multi-state, and about 15% were national. So this is a really interesting mix of folks who responded to this survey. If we can go to the next slide, please. So the very first question, at the highest level was, how important is health equity to your organization? And I think the good news here is that 95% of those surveyed felt that health equity was important. Of that 95%, roughly 50% reported it to be extremely important, and 24.5% said it's mission critical. So I think the good news here is that this is top of mind for people. It is considered mission critical or extremely important to their organization and what they're thinking about in the next 18 or 24 months. If you can go to the next slide, please. So the next question was, okay, how important is it to you? But then do you actually have a roadmap and specific action plans? And I think this is where we're starting to see that we're still in the early days of health equity. So 45.3% reported having no roadmap or not being aware of a roadmap. 45%, so roughly another half, felt that they had probably a partial roadmap, but probably not something that was formalized. And only roughly 90% said that they definitely have a roadmap, clear milestones, and activities that they need to achieve. Then we asked, okay, will the roadmap be a priority in the next 12 to 18 months? And of those that responded, 53% said that they weren't sure. So only 8% actually out of the respondents said that it was going to be a priority. So again, I think really, really important issue, but I think folks are still starting this journey. I think there's a few sort of a small group of people who are much further along on this journey that we can probably learn from. Okay, if we can go to the next slide. And then so what we decided to do then after sort of asking those questions was to peel back a couple layers of the onion and start diving into very specific tactical questions. Do you know your patients and do you know your staff? So we asked the question, do you have race, ethnicity, and language data on your patients? 43.8% of the respondents said that they weren't sure. And only 4.2%, so at the very bottom on the left-hand side, only 4.2% of the respondents said that they had that data on 76% to 100% of their patient population. So clearly a pretty big gap. And then we asked the flip side question for your staff. Do you have race, ethnicity, language data on your staff? Because ultimately, it would be nice if that mirrors your member population. And 55.2% of the respondents said they didn't actually know if they had that information. 7.8%, again, a very small percentage, actually said that they knew that they had this data on over 75% of their employees. Great, if we can go to the next slide. And then again, peeling back a couple layers of that onion, is person-centered and linguistically and culturally appropriate care available? Do you offer that? And 44% said, well, we only offer care in English. 47.9% said they do offer in multiple languages, but it tends to be ad hoc. And only 7.8% offer care in multiple languages. So again, very much mirroring sort of what we saw on the prior questions around knowledge about your population. So roughly 8% of folks, respondents really understood a lot of the details around these types of issues. Next slide, please. And so the very last thing we asked was just sort of free-form text. What's the biggest barrier preventing you from, and your organization from starting this journey of health equity? And we did a word cloud here, and it's much more detailed in the report, but the biggest thing that came up was data challenges. So that was absolutely number one, I think, and that was certainly reflected in the prior questions where there was a lot of uncertainty on whether they actually had the critical data around their patients and their members. Along with that is budget, leadership, prioritization. So I think a lot of health plans and a lot of providers, they're very complex businesses, lots of different priorities. And I think there's just a lot of competing priorities. So I think for us, because this is the first year we're doing this, we sort of see this as the glass half full. We see this as we're just literally in the first steps of a marathon, and this will be a marathon, a long journey for the healthcare industry. But the good news is that this is a priority, and there's a lot to do, but I think there's a lot of folks who realize that this is a priority and will hopefully drive that within their organizations. Okay. Great. Let's switch to the main part of today's event, which is speaking with our distinguished panel. And what we'll do a round robin. So I'm going to actually start with our first panelist, Dr. Chris Esquera, and we'll ask a specific question around sort of his point of view. But before he starts, I'd love to introduce Chris. So Chris is the Chief Medical Officer at Health Plan San Mateo, covering Medicaid and duly eligible Medicaid and Medicare beneficiaries. He is an experienced healthcare leader focused on equity, delivery transformation, integration, and novel payment models. So Chris, based on sort of what you've heard, your experience, would love to get sort of your 5-minute take, especially from a viewpoint of a payer and somebody who's been doing this quite a bit, on sort of what you've heard, what you think about the state of health equity in the industry and with payers.
Yeah, thanks, John. I think the place to start and really just with these survey results, it reminds me of when we all started talking about social determinants of health many years ago. And again, it's just the nascent nature of it. Now we're moving more just talking about social factors and then how it's evolved. And here, when we talk about health equity, I think it's theoretically, we know that it is the right thing to do, as you pointed out. The question starts to become, what do we do about it? And how do we begin to implement things? Starting with where I work and the privilege that I have with being at Health Plan of San Mateo, the nice thing is, and our whole vision and mission is healthy is for everyone. It's built in, health equity is built into that vision. And I would think that for many of us organizations in healthcare, that is what we are opting to do, wanting to do. And maybe to really kind of hone it in a little bit, no matter what, health equity is your journey to do better for the population that you serve. And then that starts to ask start asking the questions of what does that actually mean? And I'll say that many plans and many organizations that I've seen, when starting in this arena, trying to just have better health outcomes from an equity perspective, really just start in the arena of data. And that was definitely the last area that you pointed out from the survey. And our colleague, Dr. Melissa Clark, will address this a little more. But that ends up being a little bit of a head scratcher. What do we do? Ultimately, though, I think more important is just really thinking about what's the larger framework in order to really integrate efforts around health equity into the work that you're already doing. So, of course, data and the interventions related to what the data shows and reveals is a part of that. However, in one of the survey questions, talked about staff, and I think it's also then important to have that internal look. What is it about your staffing? What about the capabilities of the organization from both your staff, your tools? Also, a really hard look at your processes and policies that may contribute to inequitable outcomes. In addition, there's also this other aspect of, while you're doing the work, then you're going to start thinking about what about the external pieces. Yes, there's the work in supporting the populations that you're wanting to support. However, quickly you'll get to learn that you're going to be thinking about partnerships in the community, partnerships with providers, understanding that, yes, we may address social factors, but then we may need to also understand what are the policies around making sure that there's actual equitable access to food. What about transportation? So larger and structural environmental pieces, policy pieces that become important. And then really understanding your role. Is this a role of, is this something me and my organization can do? Is this something that I have to partner with, pick whoever, community-based organizations, providers, governmental organizations, or is this where things are already happening? I will be happy to be a cheerleader and make sure that continues to happen and lend my support wherever. And these are really important things in understanding and how then we can begin to do that. And Dr. Amy Helwig will actually touch a little bit on some of the policy and tools. And then Alti Rahman will actually touch a little bit on the provider side of things. But I think really it's starting with how do we start thinking about the framework, and then we can begin to execute from that framework.
Great. Thank you so much, Chris. Let's move to Dr. Melissa Clark. Dr. Clark is the Senior Medical Director of Healthcare Transformation and Health Equity at 3M Health Information Systems. She's an innovative leader in population health, clinical quality, and health equity for Fortune 500 companies and healthcare organizations. Dr. Clark, from your perspective around data and just in general from your career, sort of what are your initial thoughts on health equity? What are some of the things you've seen organizations struggling with, and what's your advice?
Absolutely. Well, thanks, John, so much for having me. And I wanted to just pick up on a point that Dr. Esquera made regarding data. Data really is in service to strategy, especially when it comes to addressing health equity. Our organization first has to have equity as its organizational priority, be very intentional about that. And underlying that is understanding that health inequity has power differentials built in. So bringing about equity in health really requires lessening that power differential by, as Dr. Esquera said, diversifying your workforce to reflect those who you serve, involving trusted members of the community and community-based organizations in decisions that affect the community that you serve, and how to figure out who those people are. You just ask your members. And then being willing to make systems changes to remove the barriers that make it difficult for people to have access to care and positive health outcomes. Having the right data really helps to support these processes. You really have to understand your members, who they are, and then how their lived experiences intersect with their healthcare utilization, and their health outcomes. Of course, the lived experience is what's called the social drivers of health, your culture and your primary language, which can both be a source of resiliency, but also a challenge due to racism and discrimination. The challenges of daily living, having access to clean air, water, clean water, transportation, economics and employment, which are often prescribed by our neighborhood, health behaviors like smoking and substance abuse, seeking preventive care, exercising and eating nutritiously. Those often too relate back to your neighborhood and your economics. So your propensity for healthy behaviors is tied to your access to mental and physical health care, safe outdoor spaces, and healthy produce. So really understanding these factors in our population from the social perspective has always been important, but of course with provider accountability for health outcomes under value-based care programs, which we're slowly moving more towards, we have to take into account this large influencer of health outcomes, social drivers, and really make sure it's baked into the picture of understanding our population. Those data on social drivers really help to shape our understanding of both the social challenges that the members you serve have, and importantly, as I mentioned before, how they intersect with the clinical burden of illness to then affect outcomes. Risk adjustment becomes essential in comparing outcomes across patient populations, ensuring you're making fair comparisons when it comes to the clinical complexity of your patient, to make sure that you're comparing apples to apples when you're looking at allocating resources to a particular issue or looking at how your outcomes differ. You have to have that really firm foundation and in the understanding of how complex your patients are clinically, who are your sickest patients, and how they're utilizing healthcare. So on average, we know that the sickest 5% of our population tends to use about 50% of our healthcare services. And then if you layer standardized social determinants of health data on top of that, you can then compare outcomes across the board when it's time to understand what resources need to be allocated for which patients who might have a similar clinical complexity, but maybe a vastly different level of social complexity. And then that risk-adjusted clinical data coupled with social risk data helps you determine what are the barriers to accessing care for your population. Who is that 5% of your population that requires 50% of the care? Those are the folks that you're going to want to focus your resources on, and then further segment your population to determine which hyper-targeted social determinants or social driver interventions are needed. For example, your members with high severity diabetes who are on multiple medications with complications or other comorbid conditions, who might be nutritionally insecure and live in a certain zip code, for example, might be who you want to work with first. So that helps with that prioritization. And then you can also see how the interventions that you're making are moving the needle on risk-adjusted health outcomes over time. So there are many clinical classification systems to choose from to determine clinical risk and perform risk adjustment. I'm at 3M, and of course, the one that we provide to clients are our clinical risk groups. They're claims-based, they're clinically not financially derived. They're based on a person's diagnoses and how those diagnoses interact with each other to multiply risk. And they can also, you can also layer on a person's functional status or the social drivers of health to understand again how that's affecting their clinical outcomes. And then once you understand how your population is segmented clinically based on the social and the clinical factors, you can see what utilization looks like. So using potentially preventable events like readmissions, admissions, ED visits, outpatient services, and complications, you can really understand the utilization patterns of each of your cohorts based upon their social and clinical risk, and compare utilization and outcomes for each of those groups to understand how you're performing in closing health inequities in your population what are the social factors that are most influential, which hospitals, practitioners, geographies, ethnicities have the highest risk, and how you can point your laser focus in the direction of the right interventions to do. And then finally, I just want to close, since we're talking about data, knowing that data can have bias. For example, utilization data may be biased against those who don't have access to care, right? So it's important to understand that that bias might adversely impact the quality and level of care delivered to beneficiaries. To do this, your data analysts and users have to be really cognizant of the way that you capture and analyze your data and where those bias pitfalls might be hiding.
Thank you so much, Dr. Clark. Now we'll move on to Dr. Amy Helwig. Dr. Helwig leads RTI Health Advance. Previously, she held positions at the U.S. Department of Health and Human Services, at the Agency for Healthcare Research and Quality, and served as Chief Medical Officer and Director of Health IT Safety and Clinical Informatics at the Office of National Coordinator for Health Information Technology. So Dr. Helwig, given your background, not only in government, but also as a practitioner and now at RTI Advance as a advisor to lots of different organizations, whether they're payer or provider, what is your sort of perspective on this whole discussion around health equity? And in particular, you know, we know that policy ultimately drives action. And what are your thoughts on sort of where policy is going?
Sure, thank you. Well, we're definitely seeing progress or enablers on multiple fronts when it comes to both policy and research. And in some cases, this is rolling out almost as a condition to operate or a condition to bid, certainly when we look at reimbursement and payment policy. If we just start first at the national level, we're seeing some new adaptations out of CMS to some of their alternative payment models, such as the changes they've done to their ACO program and now converting it to ACO REACH, which has much more of a focus on health equity and those outcomes, as well as the newest generation that was just released for the oncology care model. And when you look at both of these alternative payment models, some of the requirements that are being built in are that these providers work to collect those social drivers or social determinants of health, put together health equity plans or action plans that they can do at their community level, and then putting in processes to actually measure a change in outcomes and differences over time. A second action that's happening at the national level when it comes to policy is around incentives. And CMS has just begun to introduce some incentives that are designed to increase the percentage of the United States population, all of us, that are touched in some ways by these value-based payment models with equity requirements, by getting us to have more providers in those models so that we're starting to see those providers in our day-to-day practice. National is at one level. A second level would be states, and we have a good number of states. We have 50 states, and as you can imagine, there's 50 different policies at that state level. But the general theme that we're seeing certainly is an increase again in requirements around and building in these requirements around health equity. The way that it is tending to roll out at the state level is really directed to managed care organizations that are contracting with states to deliver Medicaid services, manage long-term support services, and other care management programs for special needs populations. And like I said, the main difference between the state and the federal is that the state, there's very significant variation state to state in terms of when and how and the level to which those are rolling out. On the accreditation end, with NCQA, they've rolled out their new Health Equity Plus accreditation program. And this is a program that any health plan can apply for and become designated as having this Health Equity Plus certification if they're able to demonstrate that they have not only the infrastructure in place, but the programs and the actions that are taking place at the community level to be able to demonstrate that impact and outcomes long-term when it comes to equity. One of the nice things about the NCQA program is for employers, large employers that are looking for trying to figure out what can they do around actions around health equity. One thing they can do is they can look towards health plans that their employees will see or that will be in their communities with their employees. And through this designation program, they can pretty easily identify which ones are pursuing that NCQA accreditation program. So that's a quick snapshot of what's happening at that policy level. This is matched with an acceleration on the research end, and especially that data models end that really can enable and provide the tools that are needed so that all these action plans can take place. What we're seeing with an acceleration on research is the research is now focused on trying to discriminate and find those nuances in terms of what really is working at a neighborhood level, at a clinic level, at an individual level, and not so much at the higher outcome levels, but really trying to say, how do you have to customize and how do you meet that individual patient where they are at their neighborhood so that you can have the most impact and where's most needed there. And certainly we have much more sophisticated data models that are rolling out and that are combining different data sets so that you're able to have more precise identifications of neighborhood and community trend, not only what's happening at the baseline, but also what's happening that you can measure change over time. So as all those requirements and policies roll out, these databases are going to be critical because that's one of the only ways that we're going to be able to determine whether or not we're making a long-term impact.
Great, thank you so much. There's a lot to unpack there, and I'm sure when we get into the other questions and questions from the audience, there'll be quite a bit more around that. And finally, last but not least, we have Alti Raman. Alti is the practice administrator for Oncology Consultants, a large community-based oncology group in Texas. He's also on the board of the Community Oncology Alliance and chairs their Health Equity Committee. So Alti, oncology is the biggest single driver of cost in U.S. healthcare. How do inequities show up and what can be done to address it?
Thanks, Sean, and really happy to be here and participate in such an important discussion here. So I think I'll build this into kind of two different frameworks here. So number one, as the administrator for a cancer practice, one of the things that's that's always that we're reminded of, that a cancer provider is downstream of various life experiences of the patient. So when we have a patient walk through our doors at the average age of 55 to 60 and up, they've gone through a set of life experiences and a set of circumstances, life events, that's going to have a very important impact into how their cancer journey could progress in terms of it having positive outcomes, poor outcomes. So our ability to intervene and manage those outcomes, a person, a consumer, a patient has gone through so much already, that our ability becomes, in terms of what we do in making sure patients get treatment started on time, making sure that they have access to other services through hospital systems and other community-based resources, we somewhat get limited in the impact because there's so much that's happened. So that's number one. We're very downstream of the patient or consumer experience. Number two is that as we are downstream, one of the things that we recognize, and our practice located in the fourth, soon to be third largest city in the country, we represent a very diverse. We're a very diverse city, diverse population, and the way we take care of our patients using our information and technology, certainly how we make sure we start patients on time. One of the things that we're always reminded of is that the data that we put into our systems in terms of getting different drugs, and when we need to start it and what dates we need to start it and how we manage the dosing. One of the things that we're always reminded of, that there's one common denominator here, is that no matter how well we tailor our processes from an information system standpoint, turning data into action and action into then wisdom, the main thing that we're always reminded of is that patients have a trust issue. There's a mistrust of the healthcare system. So as we think through the care processes and how we train our staff, it becomes very important that our practice builds this focus on health equity into the foundation of what we're doing, and reinforce that foundation, reinforce and make it part of our DNA, that we have to make sure that our staff is representative of the population that we serve, that they're culturally sensitive, culturally competent in the various needs of our populations. We serve a large Hispanic population, Vietnamese population, and other demographics in the city of Houston. So we're always reminded that the sophistication of what we do from a electronic information management, data to action, that trust is the most important thing, and the interaction with the provider and the staff, that trust and how we build trust is something that we have to provide proactive education and continue to reinforce it. And the thing is, as a cancer provider, certainly our priority is to take care of our patients, but it's as a representative of the provider segment and what we're seeing in the country right now around provider and staff burnout. This is something that's important, that our staff are also part of that health equity and health disparities dialogue as well too. So how we as an organization take care of our frontline staff and make sure that we are applying the same thinking and thoughtfulness around what we do with patients with our staff as well too. That's something that that we know that we have to continue to do a better job in. And then so that's kind of so the cancer experience one is downstream. And then as we go into kind of what needs, we understand that part of that downstream experience depends on the how other organizations look at health equity in the cancer space as well too. So part of my role in what's with Community Oncology Alliance with the Health Equity Committee is that we understand that in order to make sure that health equity proceeds in a direction to where it creates optimal outcomes in the cancer experience, we have to partner with other organizations in the country as well that may not be making this a priority just yet. I think your survey was very important to demonstrate that we are on different pages. While there may be priorities set by payers in terms of what's the roadmap, what's the action plan, we have to make sure that as representatives of our different stakeholders, and I'm joined here by my wonderful colleagues that represent all these different areas, that we're moving in the same direction. And last but not least is that the payment model in the country right now is reactive and it's quantity based. Those two factors have to have a major paradigm shift. Being reactive and being a quantity based health system needs to move into a new definition of what value-based care and what managing costs in healthcare means, basically. So we have to look at not just how we think about the cancer experience and how do we pay for health equity interventions in the cancer experience, but how are other connector and feeders that go into the cancer experience, the primary care physicians, the large health systems that refer out to oncology providers, how do we streamline not just clinical interventions, but how do we make sure that the financial aspects of it are also agreeable with each other? So where we're not having a quantity-based type of economics on one side and a quality-based economics on the other side. So that's an area of importance for me and for the Community Oncology Alliance, is how do we build these bridges together.
Great. Thank you so much, Alti. I'd like to do one last round robin, and this is a bit of a quicker answer, although it's a pretty important issue. So I'd just like to go back, starting again with Dr. Esquera, and then going to Dr. Clark, Dr. Helwig, and Alti. The question, is that I think health equity is the right thing. Doing right by your patient is the right thing. And then at the beginning of this event, I cited a few statistics at the national level for how much healthcare is being impacted and how many wasted costs through health inequities as well as productivity. But I think when you get down to the granular level, down to specific provider groups, specific plans, what is the business case? And I hear, as I go across the country, I hear lots of different comments, questions. Some people aren't quite clear. And if you saw in that word cloud, after data, the second issue was budget, and the third issue was prioritization, because these organizations have lots of things going on. So maybe starting with you, Chris, if you could maybe just give a minute on sort of maybe very tangible examples of where you see the business case and how we can convince other folks that there is a real business case here.
Yeah, it's a great question, John. And you're right. It's while we could carry the flag and say this is the right thing to do, ultimately we're going to still be we're going to still have to be accountable to other important factors that's just part of the business consideration. And part of it really is, one, there's a narrow return on investment argument, which is financial. And then this is where I start to argue there's a broader return on investment argument that it's more than financial, and we'll get to that. The reality is inequitable outcomes lead to certain populations, therefore having poor health statuses, and therefore using higher levels of care because we never went upstream to address the issue in the first place and pick whatever those issues are. And so with those inequitable results leading to just these unfortunate outcomes, hospitalizations, increased emergency room visits, just by addressing and trying to put in interventions that are going to have equitable access, have equitable control of diabetes, for example, or controlling blood pressure, pick any of those things, we're then going to be saving. And even I'm just thinking about one example where this was years ago with another Medicaid plan, and I'd asked the question, I was really interested in C-section rates and said, hey, let's take a look at our data and just look at it by race, ethnicity, and zip code. The first question back actually was, we have that data, of which the answer was, yes, we do have that data. It may be imperfect, but we have it, let's do it. And lo and behold, we sliced and diced it by race, ethnicity, by zip codes, and by also hospital. So all of a sudden now on my hands, I had this information of inequitable outcomes by way of C-section rates, by hospital, and by zip codes. And so it started us on this journey of how do we begin to actually address this. It ended up being a much more multi-pronged effort of talking to OB groups, much more work with specific communities, because we then got to see which ones needed a lot more support, who we partnered with. Turns out we actually were going to save money just by reducing the C-section rate broadly for those groups that had higher C-section rates. We started to see, I believe it was every 2% was about $500,000 in savings.
Wow.
Go figure. And that's just on the payer side. But then we start thinking about, wow, more women went through a better pregnancy experience, for example. So what does that look like? So these are some things that I think we need to be thinking about. And so then gets to the broader ROI, because we start thinking about the wrong pockets problem. Because while it may be a wash financially, we may be saving other parts of the system as well in other areas. And again, we're affecting, hopefully positively, the life of individuals within these affected populations.
Great. Thank you so much for that example. Dr. Clark?
So I mentioned that 5% of the patients in general consume 50% of the costs, and those social drivers affect at least 50% of those outcomes and costs. So to understand ROI, you really have to understand the costs associated with the population according to their risk-adjusted clinical complexity, and then see how those social drivers are impacting a particular cohort of members, and which social drivers are having an additive impact. For example, in work we did with a health plan in Florida, we saw that health literacy had an outsized role to play and the highest correlation with a higher burden of illness. So even above and beyond food insecurity, housing, transportation, and economics. You can then, once you have that understanding, see how closing the gaps and addressing those social drivers compares over time and bringing down your total cost of care. I just want to throw in a word about Z codes because that was in the chat as a question. They're a way to ensure that those Z55 to 65 codes are the ways to ensure that social drivers of health get into the clinical record and can be included in understanding the social risk of your population. So I mentioned that CRGs can ingest Z codes. We're continuing to build out that capability for audiences to auto capture their Z codes from social risk drivers entered into the chart by non-physicians like social workers, prioritize those Z codes so that they get into that top 25 that then go on to get submitted to the payer. And then on the pop health level, continuing to refine the algorithms for how Z codes impact the clinical risk. A couple of cautionary scenarios. Total cost of care, expect that it's going to increase first before it decreases, because if you're doing things right, you're getting more people in for preventive services and possibly identifying diagnoses that had not previously been treated. And then part of the challenge with value-based care without an understanding of social needs is that those providers who have higher burdens or higher numbers of socially advantaged populations will be able to meet quality metrics with less effort than those who are serving more disadvantaged populations. We've seen this with ACO models like the MSSP, in which practices with more socially disadvantaged members either didn't participate or didn't realize the same levels of savings because social risk was not included.
Got it. Thank you. Dr. Helwig, and then we'll go to Alti. And we have quite a few questions coming through. So if you can just keep the responses short, because I'd love to get the audience a chance as well to get their questions addressed.
Sure. Well, I'm a believer that taking actions towards equitable outcomes and quality raises all boats and improves healthcare for all. When you look at successful interventions, a large driver of the improvements and results it's an allocation of the healthcare dollars, not only just the dollars, but also the healthcare providers, staff, and the time for actions and programs, because these programs result in less unplanned care, fewer readmissions, improved outcomes, and increased medication adherence. That then frees up resources. You kind of heard this upstream, downstream discussion. That removes resources upstream so that you can better address and prevent complications for all and really work at those social drivers at the community level. So I'm a believer that it's just a redistribution, and it's distributing it in a spot where it actually will have more impact.
Yeah, I think so. Our practice, we're involved in multiple value-based care, where we have 6 different value-based care agreements, and one of the things, and the main common denominator of any value-based care agreement is risk. How much risk is a provider going to take in exchange for some sort of exchange of, preferred status in a population or in a network, basically, right? So, and the thing about these risk programs or value-based care programs, whatever you want to call it, is that they're designed based on retrospective claims analysis, which, I would say the majority of them did not had an absence of any health equity interventions. So you're looking at, these episode costs or perhaps even DRG costs that are built without, historically, and I'm speaking very broadly here, that didn't have those interventions built in. So my colleagues here, Dr. Clark, Dr. Esguerra, Dr. Helwig, as we're talking about, as we start having a proactive management of these health equity initiatives, certainly initial claims costs could go up, but you're looking at in a cancer patient, in our world, in the cancer experience, when and if they arrive to that point, the presence of interventions is what's going to hopefully have it to where you are not seeking high cost, low value sites to get interventions, like going to the ER where you could have gone to see a provider. So I think the economic model is definitely there, but I think there was, but you have to start building it right now in order to see that cost of care start coming down progressively.
Thank you. Rachel, I know we've got quite a few questions coming in. Do you want to?
We do.
Let us know the
We
first
do
one?
indeed. Very exciting. I will ask folks to try to be brief with their responses, just so that we can get in as many audience questions as possible. So the first question is for Amy. So Amy, over the next 1 to 2 years, what should healthcare entities focus on to improve health equity? People, process, or technology? Amy, you're on mute.
Yeah.
I say the first priority is just get your baseline data. figure out your baseline data, what's happening at the neighborhood level, because that will help identify either your clinical or your quality issues. Then going out and meeting with the community and engaging with them and putting a solution through together, getting the local champions. Start small, build on success, and then scale. But before you even get to people, processes, or even technology intervention, you've got to just get that baseline data at that neighborhood level of what's going on.
Got it. Got it. Always the data, right? Absolutely. All right. The next one is for Melissa. So Melissa, great insight on total cost of care first, going up before falling while addressing social determinants of health. How long does it take for this initial trend to reverse?
I think that's really dependent on the, what the trend is that you're looking at. For example, by risk cohort. And so I would say, don't look for savings in the first 2 years at minimum. Expect that it will come after that once you get folks in for preventive care and you start to see the downstream effects that I think Amy really excellently outlined in terms of medication adherence, decreased ED usage, decreased hospital admissions, et cetera.
Great, thank you. This one's for Chris. So Chris, implementing programs for health equity requires an investment. What is your payback timeline to make this investment case sellable to the financial executives in your organization?
Yeah, that's a great question. The tactical answer is it depends on the timeline your financial executives have set on what interventions you actually want to do. And it's going to sound slightly cynical, but if the focus is more immediate, then go ahead and look at the high cost things that you're going to address from an inequitable outcomes perspective. And we've already addressed a number of those: readmissions, unnecessary hospitalizations, emergency room visits, things like that. I like to package things. And really, I like to approach things from a holistic perspective, because sure, I'm going to work through savings in those high cost areas, but yes, why don't we engage with the community to do something better that will actually also save in these particular areas financially, but we're going to then invest in these particular areas. And so, so as an example, just this idea of let's just re-envision pregnancy as an experience for a Medicaid population. That typically, unfortunately, the story I would get from the OB groups was that I'm seeing them at week 30. This is way too late. So in addition to addressing the contracts we had with hospitals and OBs, in addition to the statewide work around reducing C-sections, we were actually working closely with community-based organizations that actually partnered with women in terms of just parenting and coaching and evidence-based models that actually supported them through a pregnancy. We did a lot of work with primary care in terms of the identification and quick referral to local programs. We released an app that was pretty much what to expect when you're expecting, but in an app-based model that pretty much helped you day to day what you're going to do. So it was very much a layered effort. And that got funded and supported because the top level ROI was the reduction in C-section rates. So there's a way to do it. You can be very strategic and tactical, but first question is, how soon do they want those savings? Because the reality is some of this work, it's going to take time. And as what Dr. Clark pointed out, some of this you want actual utilization happening, because for a group that was disadvantaged, probably access to care was one of the things where it wasn't happening. So you want that increased cost because that's a good thing.
Great, Chris, thanks so much for that. So we have so many more questions and are unfortunately not going to be able to get to all of them. The good thing is we will be answering them, absolutely. So there's a follow-up message that will go out and you'll be able to get some of those questions answered. But I'll turn it back over to John for the last couple of minutes.
Great, thank you so much, Rachel. Maybe I just did want to close with a little bit of inspiration from all the panelists, and maybe we just do a sort of rapid fire 30 seconds, again, going in the same order, starting with Chris. what is something really tangible you would recommend to a plan or a provider right now to just get started on the journey?
Get your framework going. You already have people that are passionate about this in your organization. Work with them. They have ideas, support them.
Thank you. Dr. Clark?
Yes, figure out your data plan, how you're going to collect your data, and then once you prioritize your data collection, how you're going to organize it to find the insights that are necessary to develop your roadmap.
Dr. Helwig?
I'm a data person as well, and collecting data takes time. So before you get, well, collecting data is great. Start with aggregate data. There's great aggregate data databases available that can give you neighborhood level data that can then guide what other data you need to obtain.
Thank you. And then last but not least, Alti.
I'm a data person, but I work in a provider practice. So I'll give a two-part quick answer here. So it's the dialogue. You have to have it. The very simplest way to start is having that conversation. It's not just about, how quickly or when can we start your chemotherapy, but let's start that dialogue, train the staff in terms of how, they're going to create that conversation around social determinants of health. And then an extension of that dialogue is we have industry partners. The payers are certainly a very important part of that. Start the dialogue with the payers as well, too, because if you're there was a question in the chat box around getting payment models. Payment models won't start if there isn't a priority congruence between the provider and the payer. So start the dialogue with the staff, make sure that they're involved in the discussion, and get your stakeholder like a payer involved as well.
Good. And I think in the spirit of starting with the dialogue, I just want to thank all the panelists for participating today. I think the purpose of this survey was to really start that dialogue. And I hope partnerships, collaborations come out of this. And I hope that next year and the year after and the year after, as we keep on doing this survey, we'll find the needle really moving from it's important and we have a plan and we're actually doing something about it. So thank you, everybody. There's a lot more to discuss, but I'll hand it over to Rachel, who will close us.
Fantastic. Well, thank you so much, everyone, for such a fascinating and informative discussion. Thank you to the panelists, of course, and thank you to our audience for all of the great questions that you submitted. As John mentioned, we will be sending out the white paper, kind of telling you a little bit about that survey, some of the results and what it means for all of us. So keep an eye out for an email from Vantage Health Technologies. It'll also be available to download from our website and our social media channels, and we can get those links out to you. Again, thank you so much for everyone that submitted questions. We will be doing our best to answer all of them. So please don't think that if your question wasn't answered, we're not going to be following up on that. There were a couple comments and questions around how can folks stay in touch with these panelists and continue this conversation. And so when we send that follow-up email, we'll be providing contact information, and this will certainly be hopefully the first of many really, really important conversations around this topic. So thanks so much, everyone. Really appreciate it.